তোরা সবাই জিএনআইডিএস আর তো ওকে, ঠিক আছে, অলরাইট। তো লেট আস বিগিন। তো আচ্ছা, bioequivalence we have already discussed. So bioequivalence is all about your like between two companies, the two different drugs which are there, so those drugs are same or not. So that was the last thing that we discussed. So next thing that we will be discussing, that is about the bioavailability. Now I have told you what is, I have explained what is bioavailability, like how much of the drug is available in the bloodstream. Basically from the word you can understand how much of the drug is available biologically. So what are the factors that can come up? So number one is first pass metabolism. First pass metabolism. Now what does it mean? It means that when the drug gets inside your body, as it passes through the liver, it is going to undergo metabolism. So that is the first time drug is undergoing metabolism. Before that there is no story of any metabolism. This is the first time any metabolism is taking place. So that is called as a first time metabolism as it passes through the liver. So that is first pass metabolism. Next thing that comes up, that is I'm going to discuss all of these things, don't worry. Next thing is the solubility of drug. So how much it is soluble in your bloodstream. So that is very important. Next thing is how much is soluble in your bloodstream, or how much will be available in your bloodstream. That will be decided by what is the nature of formulation. Like we have discussed, whether it is aqueous soluble, whether it is aqueous insoluble, whether it is polar, non-polar, oily, watery, what kind of formulation, whether it is dispersible in in the aqueous phase, or it is in a very compact form. So nature of formulation is very important. Next comes up, of course, chemical instability. Chemical instability means you are this bioavailability when we are talking about. So whether you are directly putting it in the blood, or whether you are passing it through your stomach. So if you are passing it through your stomach, then lot of enzymes will work on it. So whether it will be chemically stable or it will be chemically instable. So chemical instability is also very important, because enzymes do have a role in the entire drug thing. And finally comes up something called as a therapeutic equivalence. So therapeutic equivalence is somewhere similar to this bioequivalence. That is, we want to know about how much effective it is. I'll talk about it. Okay, so if we talk about bioavailability, so how can we make a drug 100% bioavailable, 100% biologically available to your body? So like if you are taking 100 milligram of say any drug, and I want 100 milligram to go into your blood, how can I do that? Very simple, just inject 100 milligram drug inside the blood. Simple. That means IV, intravenous. So unless and until you give intravenous, there is going to be some problem. There is going to be some percentage going to the blood, but not the entire blood. So like suppose if you are giving IM, intramuscular, then also there will be a lot of enzymes present in the muscles which can work on it. If you are taking through the enteral route, then to again lot of enzyme, loads and loads of enzymes will be present. Okay, so that is the thing, that if you want 100% bioavailability, so you have to go for IV administration. Now if you are taking it orally, like I said, the concept of metabolism primarily comes up when you take a tablet, capsule, syrup, like whatever you take it orally, oral drops. So whenever you start taking it through the mouth, now your drug is exposed to a large amount of enzymes. So that is very important. Now that is basically the main calculation here. Okay, now over here, if we talk about why is bioavailability so important? So I'll tell you, recently somebody asked me that like over my YouTube channel, that sir, what about the free or the cheaper drugs that are available, or some drugs are made available by our ministers and all, like from the Prime Minister and all. So these drugs are very cheap as compared to some proper branded drugs. So should we buy it or should we not buy it? Why is it so cheap or something like that? So they asked me this question. And why the doctors don't write those medications. So So this is something that I explained to the person, that the concept is bioavailability. You know, it's very difficult to explain it to a layman, but I can explain it to you. So it all depends on the sensitivity. Ideally, you are buying, say, paracetamol, 650 milligram of paracetamol. Let's say you are buying Crocin, a branded company. Okay. Another thing is, you go to the shop, and in that shop you into the free shop, okay, or the fair price shop, and you get paracetamol 650 milligram. Ideally, both are supposed to be paracetamol. So talking about officially, the government is not at all bluffing. Actually, government is definitely helping us, be it like at the state level, the fair price shop, or the, you know, we talk about the Pradhan Mantri, those Yojana and all those things. So nobody is they're doing bluffing games. Now comes up that why doctors always prefer brands. So like that person asked me that is it all about commission and all these things? Not at all. Like, see, in every place there can be some unscrupulous activities going on, some illegal activities going on, but always you can't say, like, universally it cannot be like that. So then the government will start taking action. Okay, so actually there's this commission wala, that mind game, that is a very cliched mind game that doesn't work everywhere. So then why a doctor writes such kind of branded medication? The answer is bioavailability. So suppose let's talk about that Obirup owns a company, and let's say Shomili owns a company, and Devashmita owns a company, a pharmaceutical company, okay, and three of you sell paracetamol. Now what happens is that, let's say Obirup is a very big businessman, or he's a person who has got a lot of money, and he has opened a very high-tech lab and manufacturing unit, and he has procured the best machines for measurement and making tablets and making capsules. Like we discussed, no, that for making tablets you have to compress the powders. So for that he has got all the best machine. Now let's say Shomili does not have enough money, so Shomili has got a decent machine, a decently sensitive machine. Devasmita has got some poorer machines, sorry. All of you are producing paracetamol only. So there is no adulteration. All three of you are very honest about this thing. Now problem is this, that Obirup's machine is so sensitive that when Obirup measures 650 milligram, so 650 milligram is there. Like when the measuring device says it is 650 milligram, that means really it is 650 milligram. But what happens is, when Shomili is using that her own measuring equipment, so when her measuring equipment is saying 650 milligram, according to the ideal standards of measurement, maybe it is not 650, maybe it is like 625 milligram. The sensitivity of the machine is changing. So Shomili is marketing the paracetamol 650. Obirup is also marketing the paracetamol as paracetamol 650. But problem is that now suppose paracetamol is such a drug that like you take a little bit 19-20 ka fark, if it is a little bit this and that, it works, it doesn't matter. But suppose a person who is very sensitive to the dosage, or we talk about some other drug other than paracetamol. So over there the problem will be that when somebody buys medicine from Obirup's brand, that person will get very good effect. But when somebody buys it from Shomili's brand, the person might not get any effect or less effect. Now again there can be another situation. Now the method that Shomili is using, that method is a standard, top-notch, state-of-the-art method of making tablet. But Devashmita does not have proper funding, so she is using some orthodox old method of making tablets and all these things. So what happens is, like we understood, there will be a lot of binding agents, binders and vehicles and a lot of those things. So maybe Devashmita is using more of those things, and Shomili is not using more of those things. So Shomili is making the tablet in a more efficient manner, and Devashmita is making the tablet in a little bit less efficient manner. Now what will happen when suppose I buy a tablet from Shomili's brand? So so what will happen is that the chemical nature, formulation, those things, they are so effectively going inside my body that even if it is 625 milligram, she's marketing as 650, and she's not wrong. If you do audit her machines and everything, will say it is 650, but actually it is 625. So, but whatever it is, but it is working. But for Devashmita, when she is selling 650 milligram, and it definitely maybe her machines are also weak or something. So again, she is also not doing any forgery or fudgy business. But the thing is this, that the formulation, the way the binding is there of the tablet, so when they are going inside my body, maybe they are getting destroyed, they may be chemically unstable, okay, so they are not soluble. Most of the drug, they are not at all like getting absorbed. So problem is, Devasmita's company is going to be a very like rough company, cheap company. Why? Because she hasn't spent much, so she doesn't need to earn much. So if Abhirup has spent 100 million or 100 rupees on his machine, so he wants 200 rupees from the patient. If Shomili has spent 75 rupees on the machine, Shomili will want 150 rupees from the patient. If Devasmita has spent 30 rupees on the machine, then Devasmita will want 50 rupees from the patient. So along with the brand, along with the brand's standardization, equipments, okay, and all those like investment, the price keeps coming down. But that is commercial part. Medically, what is happening? What is happening is that as a patient, I am getting best result from Abhirup's company, I am getting a little bit less result from Shomili's company, and I am getting very poor result from Devasmita's company. So this is one big reason why, because ideally this should not happen. Ideally, if all three of you are honest, then all three of you are selling me paracetamol only, 650 milligram. But what matters is bioavailability. In blood, how much is available, how much effective paracetamol is going in my blood. So that is the most important thing. So this biotransformation determines the amount of the agent that reaches the circulation and at what rate. So, definitely, but that is definitely that is, but in bioequivalence, one thing you have to keep it in mind, that over there the amount is has to be similar. Like if it is 650 from your side, then it should be 650 from Shomili's side, so they are same thing. Okay, so that is how bioequivalence matters. But here that can also change, that can also vary, okay, in case of bioavailability. All right. So first let's talk about it one by one. So first thing is first pass metabolism. So what do you mean by first pass metabolism? So you see, when a drug is absorbed from the GI tract, okay, first what will happen, it is going to enter the, so it goes into your gut, inside your stomach, then from the stomach, small intestine, the large intestine, and all those things. Now if you remember that as they go to the stomach, they get absorbed by the villi, the small intestine, they get absorbed by the villi, and they enter into the bloodstream. Now some of those blood, they enter into the vein, and these veins are going to carry those entire nutrition and everything to the liver, and we call it as the portal circulation, because it begins in the capillary and it ends in the capillary. So since it begins in the capillary and it ends in the capillary, so it is called as a portal system, portal circuit. So this is where our first pass metabolism comes up, because see, what I am trying to tell you is ki, suppose this is your suppose the heart, okay, and from here suppose there is a artery coming down, and let us say that this is your esophagus, then stomach, then small intestine, and all these things. What I'm trying to tell you is that, do you realize that some arteries are definitely going to supply these areas, the stomach, the small intestine, isn't it? They will be going, even they might also go to your spleen. There is something called a spleen also, graveyard of RBC. Yes, so even some of them, they can enter into the spleen as well. Now when things are going, when blood is going to the viscera, do you realize that there will be some blood that is supposed to, that will be coming out of the viscera as well? So there is going to be some of these things which come out of the viscera. Now, so this entire bloodstream where will it go? So they are going to enter into your liver. Do you know this? They will enter into your,
Yes.
the triad, the portal triad. They will enter over here. And just to complete the picture, I must also say that from here, Aja, also you should know this thing, that this portal vessel, this has too much high amount of oxygen or less oxygen. What do you think?
Sir, oxygen that forms at the less than.
Exactly. So if oxygen is less, do you think liver should survive? Nah. So liver needs oxygenated blood also. Who will supply? Definitely hepatic artery. So in this way, this hepatic artery is also joining here. If you remember the portal triad, hepatic artery, hepatic portal vein, and bile duct. So but what we see now, that all the blood are going to the liver. Where will liver send them? Liver also has to send them somewhere, right? So what will happen? All of them, they will enter into the central canal. If you remember the anatomy and the histology, so they are going to enter into the central canal, and from this central canal they are going to join to form the hepatic vein, and this hepatic vein is going to enter into the inferior vena cava, and from there it is going to enter inside your heart. So that's how the entire circuit goes. Doesn't concern me. What concerns me is key over here. Do you realize that there is going to be bile duct also? So those bile duct, do you realize that they will also channelize, if you remember, and these are going to again through the pancreas, if you remember, they are also going to enter inside your intestine. Bile is entering. So if I make it a little bit neat picture, so suppose this is your liver. From liver you are going to get the right and the left hepatic vein, right and the left bile duct, and right and the left hepatic duct actually, and then you get the common hepatic duct. From the common hepatic duct, another person comes up and joins, and that is your gallbladder. So here is the cystic duct, and as soon as the cystic duct is going to join with the common hepatic duct, it is going to form the common bile duct or ductus choledochus, and after this it is also going to join with the major duct of your pancreas. What is that called? It is called as the duct of anyone? Warsang. Forgot. The duct of Warsang and duct of Santorini. So they are going to join with this duct of Warsang, and with this duct of Warsang, and as they will join, so it is going to form the hepatopancreatic ampulla, and they will be released. Where do you think they will be released? They will be released into this C-shaped. What is this organ? Who remembers?
Sir, duodenum.
Yes, they will be released in this duodenum. So you understand that how this bile is going inside over there into the intestine. So if it is going to the intestine, once again the question comes up that, do you realize there is going to be again the hepatic portal vein, which is going to again carry it back to the liver. So my point is, do you see that here there is such a nice circulation getting developed? The circulation is between the gut and the liver. What is the term for gut?
Enteron.
Correct, enteron. And the term for the liver is hepatic. So it becomes enterohepatic circulation. Do you recall? So basically that is the thing that is there in the, that is shown in this picture. Oops, okay. Just a second. So this is what is shown over here. So this is that diagram. So what we learned for any food, same thing will go for the drug also, because drug also you are taking it through the mouth only. So as you are taking the drug through the mouth, so if you look at the diagram, so you will see that through your stomach and the lumen, it is all getting absorbed by those capillary. Which capillary? The hepatic portal vein, and through that it is going to enter your liver, and then from the liver it is going to get inside your circulation. So like here it is written systemic circulation, it's not direct, like through the heart it is going to pass. So this is that thing. So it is going to enter the portal circulation before it enters the systemic circulation. So if a drug, and we know that liver is the prime area of detoxification. So you see, if the drug is rapidly metabolized in the liver or even in the gut wall during this initial passage, so the amount of unchanged drug that enters into your circulation, that should be high or low? That should be very, very low. Okay, so that is very, very low. So definitely this is called as first pass metabolism, because it is getting metabolized before it enters the bloodstream. Before the drug enters the bloodstream, it is getting metabolized. So that is why it is called as a first pass metabolism. So first pass metabolism by the intestine or liver, it definitely limits the efficacy, it limits the efficiency of many drugs when taken orally. Like we have learned in the last chapter about the routes, that there is a sublingual route, nitroglycerin sorbitrate. So why are we putting it beneath the tongue? Because if you do that, then it is going to end directly getting absorbed into your bloodstream. So the data says that 90% of nitroglycerin is cleared during a single passage through liver. Like if you take it orally, like if you don't put it beneath the tongue, if you take it orally, then 90% of the nitroglycerin will be cleared. So bachega kya? What will be left? Only 10%. So a cardiac patient, you are giving proper nitroglycerin, but still the patient will die. Why? Because 90% is gone. 90% is just evaporated. So only 10% is reaching. So that is why it is given by a sublingual route, so that 90% doesn't go off, and whatever dosage you are giving, that dose remains. Okay, and that is why if you are giving a drug that exhibits a very, very high first pass metabolism, that should be given in sufficient quantities to ensure that enough of active drug reaches the target concentration. I think in some previous lecture I have showed you that I procured one diclofenac or aceclofenac in the form of tablet, and I told you that we give 100 milligram of aceclofenac, whereas if I have to inject diclofenac IM, it contains 75 milligram. So why? Because if it is a tablet, if I have to make 75 milligram go in the blood, I have to give 100 milligram, because I know already that 25 milligram is going to get destroyed already. Okay, so that is the point about first pass metabolism. So if you are giving any drug orally, you have to make sure that there is first pass you have to make sure that you have calculated the first pass metabolism. So you have to give it in sufficient quantity, and only then the active drug amount in the blood is going to be okay. All right, so now moving on, the next two factors were, one is solubility and nature of drug formulation. So as far as the solubility is concerned, so these are very common things. Like if it is hydrophilic drug, what do you think? Hydrophilic drug, that means they are water soluble. Can they pass through the cell membrane? What is your opinion? No. Yes, that is why if they are very hydrophilic drug, then they are poorly absorbed. Okay, because of the inability to cross the lipid-rich cell membrane. But if similarly, if a drug is extremely hydrophilic, like I am talking about two extreme conditions. So if it is extremely hydrophilic, then it is absorbed poorly. But what about extremely hydrophobic?
ওটাও হবে না, কারণ হাইড্রোফোবিক মানে হেডটা তো বাইরে রয়েছে, তাহলে ওটা যেতে দেবে না।
No, that is not the issue. The issue is that if it is extremely hydrophobic, they are insoluble in the aqueous body fluid. Who will carry
ও
it?
আচ্ছা।
Blood won't be able to carry it only. है ना? So, extreme hydrophilic is also not required. Extremely hydrophobic is also not required. Now, another thing. For a drug to be readily absorbed, it must be largely hydrophobic. Okay, largely. But it should also have some solubility in aqueous solution. So that's why I have written that point that for absorption, it should be hydrophobic, yet have some solubility in aqueous solution. Both character has to be there. But main important is hydrophobic. If it is not hydrophobic, then completely gone case. So it has to be definitely hydrophobic, but like you also have to make sure this thing that it also has got some of the like aqueous solubility. And in the I think previous lecture only we discussed that most of the drugs are weak acids or weak bases. You remember? So see, this is one reason why they are like weak acid or weak bases, because we don't want the extremes. You want if you want acidity, you cannot want like extreme acidic environment. If you want basicity, you cannot want extreme basic environment. So that is why they have to be weak acid or weak bases. Okay, moving on, the next thing, chemical instability. So when we talk about chemical instability, so I hope I have already explained it, that say for example the gastric pH, that can make it unstable. Okay, then enzymes, they can degrade it. So for chemical instability, there are like these two prime important things. And of course very important is the your nature of the drug formulation. So as far as the nature of the drug formulation is concerned, so particle size, like this was the difference. Like I give you that example, na, Deboshmita's cheap industry wala. That's just example. Okay, so like how is it different from the company of Obirup and Shomili? So particle size, salt form, crystal polymorphism. Okay, then last chapter, enteric coatings. What kind of coatings that you are using? And what kind of excipients you are using. What is the excipient? Excipients is basically that binders and other dispersing agents. Okay, so they actually influence the ease of dissolution. Okay, how much it will become soluble and all those things, and that can also alter the rate of absorption. So at so many levels it can work. Okay, or it can vary. So like next comes up the therapeutic equivalence. So see, it is almost very similar. The two similar drug products are therapeutically equal if they are pharmaceutically equivalent with similar clinical and safety profile. So you see here, in one thing is added, that is not only the clinical but also the safety profile. How is safety profile coming up? That we will discuss at the end of this chapter in pharmacokinetics. Like there is something called as a safety level also. So we have to talk about that as well. So two drugs that are bioequivalent hence may not be therapeutically equivalent. So I said that it is similar to bioequivalent, but still there is that safety profile is very important. So that's why they are not same. They are similar but definitely not same. ठीक ना? Okay. So moving on. Next we talk about this distribution of drug. So when we talk about drug distribution, so you understand that once the drug has gained access to the bloodstream, it will get distributed to the other tissues. Now other tissues initially did not have any drug. So where is the how is the drug reaching? Due to the concentration gradient. Say in your lumen of the intestine there was high concentration, and then in the tissue there was low concentration. So that is how along the concentration gradient, so the direction is going to be from your blood, or say plasma, from the plasma to the tissue. So that's the direction. Okay, now the distribution is going to depend on, we have discussed, I think now you will easily understand, lipid solubility, how much it is non-polar, how much non-polar it is. Then its ionization at the physiological pH, that is basically the pKa value that we have already again discussed, Henderson-Hasselbalch, that equation. And then your how much it is binding to the plasma, that plasma proteins, and of course the tissue proteins as well. and finally in the differences in the regional blood flow. Like I think I was telling you that if you give IV, then what do? We sometimes keep doing like this, and even if you're giving IM, then you keep rubbing that area so that the blood supply increases. So difference in the regional blood flow. If regional blood flow will be more, then blood can get distributed properly. Okay, so movement of drug will proceed till the time equilibrium is established. Now question is equilibrium between what? Between that unbound drug in the plasma and in the tissue fluid. Okay, but the thing is this, gradually both will decline. See, this is the diagram I have given, that if your body is like that container, so it is not static, it is dynamic, because there is an area from where elimination is also going on. It's not that I have taken 100 milligram or 650 milligram of paracetamol, 650 milligram paracetamol enters inside my blood. No, it is dynamic. As soon as 650 milligram enters inside my blood, just hypothetical, complete hypothetical, 1 milligram is eliminated through urine. 1 milligram is eliminated through bile, 1 milligram is eliminated through evaporation, maybe as you're breathing out, 1 milligram may be going out through sweat. So immediately, like just hypothetically I'm telling you, it's not fact, that when you are taking 650 milligram, if 5 milligram is gone, so basically when 650 milligram also reaches your blood, actually it is not 650, it is basically 645 milligram which is reaching your blood. So that's the thing that I mentioned here, that movement of drug will proceed until an equilibrium between the unbound drug in plasma and the tissue fluid. They come up at equilibrium, and both are going to gradually get low because of elimination process. Okay, I think I've explained this part. So now what you should understand is that when we talk about the blood flow is very, very important. So basic funda is ki rate of blood flow to the tissue capillary, it is going to vary in different because our body has got a very nice shunting system. You know it in physiology. Where blood is required more, blood reaches over there more. Where blood is required less, there blood goes less. So our cardiac output, the heart that is pumping out the blood, that is not equally distributed. So there is an unequal distribution of the cardiac output. So normally what we see that where does blood reaches maximum? Your brain, kidney, liver. So these are the areas their blood reaches maximum. Minimum blood goes to your skeletal muscle. Even less in the adipose tissue. Okay, then your skin and like even other viscera. Okay, so what happens is that this variation in the blood flow, this is going to definitely affect for how long the drug will remain in that tissue. Suppose I want some drug to remain inside your tissue for 5 hours, but that organ has got a very high blood flow. So do you think it is going to stay for 5 hours if you are intending to? No, it will get eliminated from the tissue. Effect will be gone from the tissue very rapidly. So there is something known as a propofol. Propofol is propofol is something that we use for anesthesia purpose. So that propofol, if you are giving like hypnosis means inducing sleep. So it induces sleep in you when we do some anesthesia. So this is you should understand the variance in the blood flow. That explains the short duration of hypnosis produced by a bolus of IV injection of propofol. So propofol is given IV, but still duration of action is less. Why? Because rapid blood flow means rapidly it is eliminating it from your body. Same way, there is another drug called as thiopental. Again, these are all drugs which has to work on your central nervous system. Hypnosis, producing propofol, thiopental, they are all CNS acting drug. So once again, now thiopental has got a property that number one, ek to CNS to receives high blood supply, we have just now learned. Another thing is thiopental is lipid soluble. So what do you think? It should enter inside the CNS rapidly or it should enter inside the CNS slowly? Ek to lipid soluble. So it can pass through the cell membrane or correct. Exactly. So it can pass through the cell membrane. So it can enter inside the tissue. Plus blood flow is also high. So if you give thiopental, it rapidly enters inside your CNS and produces anesthesia. So that's the beauty of thiopental. But if I talk about, say, your skeletal muscle, adipose tissue, okay, so what happens is that there is a distribution of blood going not only to your CNS, but some amount of blood will go to your adipose tissue also, and some amount will go to your skeletal muscles also. So a subsequent slower distribution to skeletal muscle and adipose tissue lowers the plasma concentration sufficiently so that a higher concentration within the CNS decrease, and thus the consciousness is regained. Like otherwise you will ask the question that, sir, if thiopental is going so effectively and there is good anesthesia, then how will the patient recover from anesthesia? So for that, this comes up as the answer, that like suppose this is your bloodstream. So one side, what is this? So this is suppose CNS. Let's say this is your skeletal muscle. So here it is, there is rapid blood supply. So it is going over there. But what is happening, that as it is going rapidly, but some amount is also going slowly to your liver, sorry, to your skeletal muscle, to your adipocytes. Okay, but they are reaching slowly. But as they are reaching slowly ही सही, but it is becoming less available to your CNS. And again, gradually what will happen? CNS will also start eliminating this drug. So this is how the drug will become less available to the CNS, and gradually anesthesia will go away. Okay, so these are all dynamic things. You have to keep a lot of things in mind. It's not like you think about only one thing and that is working. That's why I gave this picture over here. So either way I am giving dose 10 milligram. Okay, and the tank volume is 1 liter. Okay, but the condition that you see after 2 minutes, the condition is not same after 4 minutes. Because after 2 minutes, you will see that the volume of distribution, I will explain about all this volume of distribution also, but after 2 minutes you will see that it is 5 milligram per liter. 5 milligram of drug is there inside that tank. But elimination is going on. So after 4 minutes, it is not going to remain 5 milligram because some drug has been eliminated. So now it is going to be 2.5 milligram per liter. So this is a basic, simple fundamental. I will talk the technicalities inside it, but this is the basic thing. Like as soon as you take a medicine or as soon as you take an injection, the amount of distribution that is present in the amount of concentration that is present in your bloodstream after 2 minutes, after 4 minutes, that is not going to be the concentration. So it's all dynamic procedure. Okay, so moving on. So next thing is this capillary permeability. So if we talk about this capillary permeability, so of course capillary structure and the chemical nature. So that's the prime important thing, because capillary structure also varies. Like suppose whether you have slit pores or not, whether you have the thick basement membrane or thin basement membrane. Okay, why? Because like suppose there is this third point, if you see in the liver and spleen, a large part of the basement membrane is exposed to large discontinuous capillaries through which plasma proteins can pass. I don't know whether you know this or not, but spleen is one organ where from closed circulation it becomes open circulation. Because if you see that those penicillary capillaries, that is releasing the blood, and then here there are those fibers, cords of Billroth, if you remember last year, cords of Billroth. Then there are those those capillaries, modified endothelium, they will be receiving it. So between these there is an open space. This is that area where that blood is exposed into the cords of Billroth, where your histiocytes and other macrophages will be present, who will be eating those cells up. So you see, this is not going to happening suddenly. The capillaries will become thinner, and the time will come up when basement membrane will be exposed. Okay, na? So in liver and spleen, that's what you see in case of liver and spleen. Okay, this is how even your blood cells also get removed. The damaged blood cells also get removed. Okay, now so there are two things. One thing is ki if we talk about your liver and spleen, you will see that your basement membrane is getting exposed. But what about your brain? Have you heard something called as your blood-brain barrier? So,
Yes, sir.
so what happens over there in the blood-brain barrier? Suppose this is your capillary. So if you remember, then you will also remember that here there are some projections of astrocytes. So there are these projections of astrocytes which are present over here. Remember? And
Yes, sir.
these astrocytes, they are all connected to each other by tight junction. So the blood that is present inside the capillary, that blood is not going to reach inside the brain. So in brain, the capillary structure is continuous and there are no such slit junction. So in case of normal capillaries, what we see, in case of normal capillaries, you will see that acha theek hai, so there is some slit junctions are present over here, and this is the endothelium, and this is the basement membrane. है ना? So this is going to be the basement membrane. So what is happening? So because of these fenestrations, because of these slit ports, suppose you have got some drug. So this is the drug. So some of this drug can actually come in contact. But what I'm trying to tell you is, if we talk about your brain, so suppose this is your capillary, endothelium. So this is another endothelium. This is another endothelium, another endothelium, another endothelium, and another endothelium. And even at these specific points also there are tight junction. There is tight junction in this area also. So if you have got that particular drug over here, so that drug will, do you think this will be able to touch this basement membrane? This is going to be the basement membrane surrounding the capillary. Do you think this will be able to touch that basement membrane? Of course not. So that is what is written over here. Key in liver and spleen, a large part of the basement membrane is exposed due to large discontinuous capillaries through which large plasma proteins can pass. This is in contrast with the brain, where capillary structure is continuous and there are no slit junctions. So to enter the brain, drugs must pass through the endothelial cells of the capillaries of the CNS or should be actively pumped. You have to go like enter the membrane. Like what I'm trying to say is that if it is this case, so this is the endothelium, so through this side it will enter and then through this side it will go out. So it has to go through the, like they say, no, कि जाने के लिए मेरे लाश के ऊपर से गुजरना पड़ेगा. So they have to go through the cell. Anyways, okay. So a specific transporter for the large neutral amino acid transporter carries levodopa into the brain. So this is one example. Okay. So levodopa neurotransmitter, precursor of dopamine. Okay. So L-dopa or levodopa. So for that we have got a transporter. But if we talk about the lipid soluble drug, again they don't need any transporter, just like the thiopental wala example. They penetrate into the CNS just like that because they can directly dissolve. But if it is ionized or if it is polar drugs, so then they won't be able to do that. Okay, na? So the tightly juxtaposed cells that form tight junctions. So because of this only you get that blood-brain barrier. So suppose this is one endothelium, and let's suppose this is another endothelium. So these are two endothelium. So point number one is we see tight junction here. This is part one where we see tight junction. And next thing is, like I said, that there will be present something called as your astrocytes. Like this. Now, do you know astrocytes? Neuroglial cells. So even between these astrocytes also, you will see that there is present tight junction. So there are so many levels of barrier that it's not possible for anything to just like that go inside your brain. So if it is lipid soluble only, then it can go in. Understood? Great. Now next important thing that comes up, that is this thing. This is binding of drugs to the plasma proteins and the tissues. So as far as the binding of drug to plasma protein is concerned, so there are few things that I want you to remember. So number one is that there is something called as acid glycoprotein, and basic drugs they are going to bind to alpha 1 acid glycoprotein, okay? And acidic drugs they are going to bind to the albumin. So acidic drug to albumin, and basic drug, see, it's a very common thing na. Basic drug, basic thing should have affinity for acidic things. So basic drug will go to acid glycoprotein, so alpha 1 acid glycoprotein. And but albumin binding is more important. How much is binding to the albumin, that is more important, okay? Because like we discussed, that is the one which is going to transport the drug. So extent of binding depends on individual compound, and you cannot do any generalization over here, okay? Like if we talk about data, so alprazolam, it is 70% bind to with the plasma protein. Alprazolam basically neend ki goli, like it's a sedative, okay? It comes under category benzodiazepine, again CNS drug, CNS depressant drug, okay? So 70% of alprazolam is attached to the plasma protein. But again, same category, lorazepam, we will talk about all these things. So clonazepam, lorazepam, okay, diazepam, alprazolam, they are all same category. They are all sedatives, they are all benzodiazepine. But if it is alprazolam, 70% binds to plasma protein. But if it is lorazepam, then it is going to be 90% which will bind to the plasma protein. Diazepam, 99% will bind to plasma. Diazepam is very famous. Okay, Valium, it is marketed internationally by the name of Valium by a multinational company, I don't remember the name. So Valium is very common. It's diazepam. How is diazepam so better than alprazolam? Because diazepam 99% gets attached to plasma protein, but for alprazolam only 70% gets attached to plasma protein. Okay, flurazepam, worst, 10%. Okay, so increasing concentration of the drug can progressively saturate the binding sites. Okay, and fractional binding may be lower when large amount of drugs are given. Okay, now normally though, like you understood that we always express it in percentage basis. Okay, you always have to express it in the form of percentage. Now highly plasma protein bound drugs are largely restricted to the vascular compartment. Why? Simple, it is bound drug. It's not unbound. Who will travel through the compartment which is unbound? If it is bound to the plasma protein, then how will we understand? So highly plasma protein bound drugs are largely restricted to the vascular compartment and tend to have a lower volumes of distribution. Okay, the volume of distribution will be low because, like I said, bound fraction is not available for action. Unbound one is available. Remember this: bound drug is not for action. For action purpose, unbound drug. Okay, now it is in equilibrium with the free drug in plasma and dissociates when the concentration of that free drug is reduced. It's equilibrium. Forward reaction or backward reaction? Like, there was no understanding. Like, suppose we talk about where is it? Suppose we talk about, say, bound drug. So this is one drug, and this drug is connected to your plasma protein. So this is the plasma protein and this is the drug, and in other case your drug which is there, that drug, so this is the drug, this is the free drug. So once again in between them there has to be some equilibrium, no? So bound form and the unbound form, understanding? So there is equilibrium. So if you see that the free drug is reduced, so if this level is reduced, so what do you think? Forward reaction will be favored, no? Backward reaction will not be favored. So this is the simple thing. So it is always there will tend to be a equilibrium all the time. Alright, so it is plasma protein binding drug. You can consider that it is like a storage area, temporary storage. You are storing the drug over there. So slowly, tuchuk, it will keep working. It will keep getting used up. Alright. Now high degree of protein binding generally makes the drug long acting because you're storing it more. Simple. Like when we will discuss central nervous system acting drugs, so there will be a topic where we will talk about local anesthesia. So somewhere you will read that there is long acting anesthetics, short acting, very short acting, ultra short. So anyways, all the time the reason is not same, but one way I am explaining it is that if it is long acting drug, how can it be long acting? Because it is more bound to the plasma. Okay, so that is very important. So it will not be available easily, even for metabolism also. So it will not get excreted also. If it is bound to plasma protein, that means it is neither getting excreted, it is neither undergoing fast pass metabolism, it is not extracted by kidney, it is not extracted by liver, nothing. So it is really a very nice storage form. Understanding? Now if we talk about the glomerular filtration, now this is somewhere you should understand that glomerular filtration does not reduce the concentration of the free form. Okay, so glomerular filtration will not reduce the concentration of the free form in the efferent vessels because water is also getting filtered. So concentration will remain unchanged. Along with solute, both solvent is also getting filtered, right? So concentration will remain unchanged and it is not going to be altered. Okay? But active tubular secretion is active process. There are a lot of pumps present over there. So active tubular secretion, that is definitely going to remove the drug. So like suppose there is active tubular secretion, so drug is removed without the solvent. Only the solute is getting removed, not the solvent. So concentration of the free drug is dropping and the brown drug will dissociate and then it will get eliminated through the renal clearance. Understood? So this is active tubular secretion that can alter, but not the glomerular filtration. Filtration is not going to work. Okay. And same is true if there is any active transport of some drug are there, like some certain drugs they can get actively transported. So if that is there in the liver, then so definitely that drug is going to get eliminated. Achha, plasma protein binding also is acting like a carrier mechanism. This I think I have explained already. Okay, and that is how it can rapidly hasten the elimination process. Okay, so because it is acting like a carrier, so definitely it will be carried to your kidney as well. So though it is not undergoing filtration, but it is more available to your kidney. So again, there are a lot of factors present over here. Both, see, in the kidney, both are working. Filtration not affecting, but plasma protein is making it more available, and active tubular secretion is definitely going to make the level fall. Okay, now degree of protein binding should be taken into account while relating these drugs, like relating these to concentration of the drug that are active in vitro. Okay, so in vitro and in vivo kahani is completely different. So you cannot just that is where a normal pharmacy and clinical pharmacy, like pharmacology, that's how it is different. So in the lab doing some calculation in vitro is different, but when it comes up to patients, that is different. So you have to separate pharmaceuticals from the pharmacology, like that to medical pharmacology. Okay, so reversible binding to plasma protein is going to sequester or store the drugs in a non-diffusible form that we have already discussed, and the binding is relatively non-selective. Now this is what is important, like plasma protein is not at all selective. They are non-selective regarding the chemical nature and takes place at sites on the protein to which any endogenous compound should normally attach. Like I said, iron binding site is there. Some plasma protein can carry thyroid hormones also. Some plasma protein can carry bilirubin also. Okay, so those sites are utilized here. There is no such like special site for a drug. The normal site is only used here. Plasma albumin. When we say plasma protein, we are saying plasma protein, but albumin or globulin or fibrinogen, So it is a plasma albumin. Remember, it is the major drug binding protein. Once again, MCQ, major drug binding protein, not globulin, not fibrinogen. It is albumin. Okay, and albumin is the one which acts as a drug reservoir. So albumin is more important. So this maintains the free drug concentration, or it is a constant fraction of the total drug in the plasma. Rest are utilized, but this is the constant fraction of the total drug in the plasma. One albumin can bind to only one piece of drug, one unit of drug, or many units of drug. Of course, many units. So remember this thing. There can be multiple sites of attachment. Okay, so this is, say, albumin. This is alb. Alb is not Albus Dumbledore. It is albumin. So that can have many sites. So it's not like there is only one site. No, here also one drug can bind, here also one drug can bind, here also one drug can bind. So one drug can bind to many sites on the albumin molecule, and same site can be occupied by more than one drug. Like, now this is also a tricky part. Suppose there is one drug which is looking like this, and there is another let's say drug which is looking like this. So you will see here this as well as this can also bind. So both are possible. So one drug can bind to many sites on albumin, and more than one drug can bind to the same site. And this can give rise to the displacement interaction among drugs bound to the same site, drug bound with higher affinity, competitive inhibition, non-competitive. So drugs bound with higher affinity will displace the drug which is having lower affinity. So here that enzyme substrate wala relationship will matter. Okay, so if just 1% of the drug, that is 99% bound, is displaced, so the concentration will be doubled. Do you understand that? 99% drug was bound. So out of that, if 1% of the drug is displaced, that means it is now free. Now it is available suddenly. So that the free form is getting doubled. No? Whatever free form was there, now suppose there was 100 milligrams. So 99 was bound and only 1 gram was available. Now even if 1%, that means again 1 gram again adds on, now available form becomes 1 plus 1, 2 milligrams. So it is getting doubled. So that's the idea. So, but this is of course temporary. This is all transient thing. So the overall impact of many displacement interaction is minimal. Okay, because they are not of clinical significance. Like again, in vitro it can be okay. Calculation says okay, it is getting doubled, but clinically how much significant, that we have to see, because there is something called as a volume of distribution. I will come to that point. So always remember that two highly bound drugs do not necessarily displace each other, and their binding sites may not overlap. So they can both remain over there. So I'll now tell you about one drug that is called as probenecid. I want you to remember the name, because probenecid is something which we will talk quite often. Because say probenecid and indomethacin. Indomethacin is sort of like a painkiller. We don't use it normally, regularly we don't use it. So probenecid and indomethacin are highly bound to albumin but do not displace each other. So don't think always they have to displace only, because albumin has got so much sites, binding sites, that without irritating they can take some other. Suppose in say NEET MDS there are suppose 2000 seats, candidates are 7000. Only then there will be competition. Now suppose there are 7000 candidates and there are 10,000 seats. They can coexist. You can coexist. All friends can be there and happily they can get some seat over there. So not a big deal. So it is like that. So not necessarily they will be displaced. Achha, I was talking fantasy. Okay. Achha. So anyways, moving on. No such fancy discussion. Achha. So acidic drugs do not generally displace basic drug. This is also important. Okay. Acidic drugs generally don't displace basic drug. And clinically important displacement interaction, you should remember a few examples like I have given over there. Aspirin is displacing sulfonylurea. What is sulfonylurea? Sulfonylurea is a drug which we use to treat diabetes. Okay, so diabetes wala drug and aspirin, they don't go hand in hand. So suppose you are there is a patient of diabetes, and patient says, I am having headache. You say, acha headache, acha take aspirin, no problem. No, you cannot say that. Then patients like that diabetic drug will like anti-diabetic drug is not going to work. This is the reason. Aspirin again displaces methotrexate. Methotrexate is used for a lot of purposes. We can use it in case of cancer also. We can use it in case of arthritis also. So methotrexate is displaced by aspirin. Indomethacin and phenytoin displace warfarin. Like I said, indomethacin is a NSAID, it's a painkiller. Okay. Similarly, we have got another drug, phenytoin. All these drugs we will discuss, of course, later on. They're all important. Warfarin is a drug that is used for bleeding disorder patients. So indomethacin and phenytoin is again going to displace warfarin. Sulfonamide is basically antibiotic. Vitamin K will displace bilirubin. So many a times, if there is a condition called as kernicterus in the neonates. So if there is kernicterus in the neonates, so if you give vitamin K, so vitamin K ka injection, then vitamin K is going to go and displace that bilirubin in the bound form and become freely available. Then it will get eliminated through urine. So the baby can become fine. So this is the reason. So when I'm going to teach you about the drugs, you will see there is an entire heading comes up that is called as drug interaction. Whenever you write prescription, we always ask patient, ki what other drugs that you tell us about the other drugs that you taken. So why the patients need to tell us what other drugs. Suppose you are a dental surgeon. So but you need to read the entire pharmacology. You need to read about everything. Why? Because when a patient will, you have to ask the patient that you are taking what drug. So you are, suppose you did a patient comes up with a tooth pain. You say you are having tooth pain, take aspirin. Aspirin either way works good in tooth pain, but then the patient is diabetic, so you are not a good doctor if you are giving aspirin to a patient who is taking sulfonylurea. Okay, so this is the reason you need to have these concepts. You have to know about all the chapters, you have to know about all the drugs that the patients take, and you should not give any drug that interacts over there. And that is why you should also ask. It's not like you are a dental surgeon, so you cannot ask about, you should not ask about the other physical things of the patient. You should definitely ask about the other medications. This is one big reason. Again, there is a condition called as hypoalbuminemia. Okay, albumin amount is less. So in hypoalbuminemia, definitely binding is reduced, and high concentration of free drug is getting attained. Example, you can remember these names: phenytoin and furosemide. Furosemide is what? Furosemide is used as for the kidney. Okay, so whenever you it depends, like whether you want some diuretics or antidiuretics. So furosemide is a drug that we will discuss when we will talk about the kidney related drugs. Okay, and there are other examples also, like phenytoin, pethidine. Okay, their binding is reduced in uremia. Okay, propanolol binding is increased in pregnant women and in patients with any inflammation. Why? Because during inflammation, that there is something called as an acute phase reactant. Actually, you might not know. This year pathology, you will read about it. So during that time, that alpha-1 acid glycoprotein level increases. So again, if alpha-1 acid glycoprotein level increases, then what will happen? Propanolol will get attached over there. Propanolol, it will get attached to the acid glycoprotein. So bound form will increase. Okay. Anyways, then another thing is that about the binding to the tissue protein. So this was about the binding to the plasma protein. Okay. So see, there are three things that will matter here. Number one is about binding to the plasma protein. Number two is tissue protein. And number three is hydrophobicity. So let me tell you, this tissue protein binding is also very, very crucial, important, and even for dental surgeons, this is very, very important. I'll tell you why. So see, numerous drugs, they will definitely go into the tissue, and they will definitely get transported by the help of those proteins. So if they bind to the proteins, they find. So drugs may also be actively transported into the tissue. Not necessarily that there will be only facilitated diffusion, but active transport is also, of course, possible. So these tissue reservoirs may serve as a major source of drug and prolong its action, and also cause, prolonging action is fine, but you should not prolong it in such a level that it can cause toxicity. So toxicity का reason is also same. So prolonging का reason and toxicity का reason over here is same. So there is this example that is acrolein. So acrolein is the metabolite of cyclophosphamide, which is toxic to the kidney because it gets accumulated in the renal cell to the toxic level. Tetracycline on bone and teeth. So here is the thing, you cannot give tetracycline to a pregnant lady. I'll teach you in antibiotics, tetracycline is an antibiotic. So I'll teach you that if you give tetracycline to a pregnant lady, the baby is going to have tooth color changed. The baby will develop tooth later on, which is grayish color, or it's not really the white color that we have. It's because tetracycline will accumulate in the bone and teeth. Chloroquine. Chloroquine is anti-malarial drug. Now, I think after COVID, you are all acquainted with the name. So chloroquine gets accumulated in your retinal cells. Okay, then imetin on the heart and skeletal muscles. Okay, and there are certain like not only cells which are important, but even organelles becomes important. Like tetracycline, it will get reserved in bones and teeth, but specifically it binds to the mitochondria. Chloroquine is definitely binding to the retina, but specifically to the nucleus. So even the organelles are very specific in certain drugs. So binding to tissue protein is very, very important. So inside the tissue, inside the cell, to which protein it is binding, that is very important. Okay. Finally, moving on to the hydrophobicity. So I think we have discussed it quite often. The chemical nature of the drug will definitely influence, and hydrophobic drugs will cross the biological barrier. That is the main funda. Okay, so I'm not going into again repeat discussion on this. So moving on. So yes. So here what we see. Now here I want you to know, in our body there is a concept called as total body water. Total body water, I think I was discussing this the previous day also. So there are some ICF, intracellular fluid, and there is some extracellular fluid. Intracellular fluid will include the cytoplasm, cytosol, protoplasm, those things. Extracellular fluid is going to have two things. One is the interstitial fluid that was between the cells, and the other one is the blood capillary. So this is that diagram. I hope you can see the diagram. So it is given over there. So this is about the that total body water, how the total body's water is distributed. Now we are not talking really about water, but I want you to know this because this is your body volume. This is the volume in which the drug is going to get distributed. This is your solvent. So once a drug enters the body from whatever route of administration, it has the potential to distribute into any one of these three functionally distinct compartments of the body water, or maybe they can get sequestered into the cells. So there can be a plasma compartment, there can be extracellular fluid, and there can be, we talk about total body water. So if we talk about the plasma compartment, so if a drug has say a very high molecular weight, very big molecule, so do you think they will be capable of entering inside the vascular, inside the tissues, or they should remain inside your blood? Very big, large molecular weight. So if it is large molecular weight, so they will, or if it is even, also if it is extensively binding to the plasma protein, so they won't be able to go out through that endothelial slits. So they will remain inside your plasma. If they're bound to plasma protein, same thing. So if it is of high molecular weight, or if it is extensively binding to plasma protein, so it will not be able to move out through the endothelial slit junction and trapped in your vascular compartment, trapped in your plasma compartment. So the drug distributes in a volume which is about say around 6% of your body weight, because that is a plasma. Plasma is 6%. That means the amount of distribution is also 6% of the body fluid. So in a 70 kg individual, if you are saying 6%, so it is going to be almost say 4 liter of your body fluid. Okay, are you understanding? Heparin is going to have this kind of effect. Heparin shows this kind of distribution. Okay. Now extracellular fluid, if we talk about, so now think about the low molecular weight. This was about the high molecular weight. If it is chotu, low molecular weight, but it is hydrophilic, so hydrophilic means it will be aqueous soluble. So if it has low molecular weight, that means it can pass through the slit pores, but it is again hydrophilic. So it can move through the endothelial junction, slit junction, but it will enter into the interstitial fluid. Mane, it is again not entering your cells. It will remain in the ECF. It will not enter into the ICF. Okay, so hydrophilic drug cannot move across the lipid membrane of the cell to enter the water phase which is present inside the cell. And hence, these drugs distribute into a volume that is sum of the plasma plus interstitial fluid. Okay, I'll just try to show you. When you take a drug, where does it go first? First, it is going to go to your bloodstream. So if there is any drug which is very big, or which is very your hydrophilic, so that will remain trapped over here. But suppose somebody is a little bit tiny, but again hydrophilic, so this can go, but question is not that. Question is, can it enter the tissue? No. So though it is hydrophilic, but it cannot really enter the tissue because it is hydrophilic. So where will it remain? It will remain over here in this area. It will remain in this area. This is the interstitial fluid area. ECF. Suppose this is your ECF and this is your ICF. So it will remain in your ECF. So if we talk about, say, drug 1 and let's say this is drug 2. So what is the volume of distribution of drug 1? So volume of distribution of drug 1 is only whatever is your plasma. That was that 6% of your total body weight. So if it is 70 kg individual, so 70 kg ka 6% becomes 4. That is the volume. So 4 liter. But suppose we talk about the drug number 2, chotu, but it is hydrophilic. So its distribution will be what? It is, so chotu is distributed here as well as here. In both these cases it is distributed. No? It is in like a dynamic equilibrium phase between this and this. So it is distributed in these two compartments. Okay, so that is what I was saying, that these drugs distribute into a volume that is sum of plasma water and the interstitial fluid, which together constitute the extracellular fluid. So total extracellular fluid is 20% of your body weight. So these are certain things which you must have read in your physiology about the body water. So 20% of your body weight. That means if there is any drug which is having low molecular weight but hydrophilic, so 20% of 70 kg becomes how much? 14 liter. So if you are taking a drug whose characteristic feature is just like your drug 1, so its volume, how much volume it is distributed? Only 4 liter. But if it is a drug which is a little chotu, but it is hydrophilic, then in what volume it is getting distributed? 14 liter in a 70 kg individual. ठीक है ना? So one example is aminoglycoside. So heparin will only remain in your blood, in your plasma. But aminoglycoside is an antibiotic. Aminoglycoside is a very commonly used antibiotic. So aminoglycoside will not only be present in your blood, but it will also be present inside your plasma. So that is a very important technical part. Okay, so this is, and finally I've written about the total body water. So if a drug has got a low molecular weight and is hydrophobic, so not only can it move out into the interstitium through the slit junction, but it can also move through the cell membrane into the intracellular fluid. So this drug distributes into a volume of 60% of the total body weight. Low molecular weight means it can enter into the interstitium. So it is not there in the plasma. Plus it is entering inside your intracellular fluid. So this time it is 60% total. That means this time, suppose now we are talking about a new drug. So let's say this is drug number 3. Now it is hydrophobic. So do you think it will remain in your plasma? It is small. So first of all, since it is hydrophobic, it is not there in your plasma, it is there inside here. It has entered here. And since it is tiny, it is not going to remain inside your plasma. It will go inside your interstitium also. That means now equilibrium is established between this and this, as well as this and this. Of course, I'm talking about. So basically, what I'm trying to talk about is that it is present everywhere. Drug 3. Drug 3 is present in your plasma. Drug 3 is present in your interstitium. Drug 3 is present inside your ICF. So definitely it is 60% of a 70 kg individual. That means 42 liter. So one good example is ethanol. So if you drink ethanol, so ethanol is going to stay in your bloodstream, ethanol is going to be in your interstitium, ethanol is going to be inside your cell, ethanol will be everywhere. It's so deadly. So ethanol is going to be, if you are a 70 kg man, then ethanol will be distributed in a volume of 42 liter. So that's how bad it is. Understanding? Alright. So next concept that comes up, that is called as the apparent volume of distribution. So what do you mean by this apparent volume of distribution? So apparent volume of distribution says that if a body behaves as a single homogeneous compartment with volume V, into which the drug is uniformly and evenly distributed and immediately distributed. Okay, so that is that apparent volume of distribution. So apparent word, see the word is apparent. So if the word is apparent, one thing you should understand that it is hypothetical. So apparent thing is not actual, it is really apparent only. Okay, so the volume that would accommodate all the drug in the body if the concentration throughout was same as the plasma. So this, like last time we discussed, that if blood vascularity is different, where blood vascularity is more, blood will reach more, where blood vascularity is less, blood will reach less. That is the reality. But now we are discussing hypothesis, hypothetical. So we will consider the entire volume, this thing, just now we discussed this thing. So we consider that it is totally equal, like totally evenly distributed, one big compartment, one big chamber. Okay, so see in this picture, I hope you can see this picture. The total drug in the body is 1000 milligram, but we know that the drug concentration is 50 milligram per liter. So that means, now my question is, like, how should you understand that if the drug is present in a concentration of 50 milligram per liter, so how much drug I have given? 1000 milligram. So 1000 milligram will be accommodated in how much volume? Each liter is accommodating 50 milligram. So how many liters do you need to accommodate 1000 milligram? So you see, it's a simple unitary method, isn't it? So suppose to accommodate 50 milligram, I need 1 liter. So to accommodate 1 milligram, I need 1 by 50 liter, unitary method. So to accommodate 1000 milligram, I need 1 by 50 into 1000 milligram. So basically it is 1000 by 50. See, that is what is written over here. So 20 liters I need. So in 20, 1, 2, 3, 4, 6, 7, 8, 9, 10 till 20. So each liter should, suppose you have got, this is 1 liter, 1 liter, 1 liter, 1 liter, and in this way there will be 20 such liters. Each will have 50, 50, 50, 50. So in 20 liters, your total 1000 milligram will be dissolved. But do you really understand that this is only theoretical, this is not practical. So that is why it is apparent. So that is what I want you to know. That is why the name has apparent word has come up. So you see it is written over here. So this is what I was telling. So if body behaves as a single homogeneous compartment, then what will happen? So I think they have given a formula that the apparent volume V is equal to dose administered IV. Of course, here we are considering, see in the diagram, you are giving IV inside the vein directly, divided by the plasma concentration. But do you understand that this is basic unitary method? So if you are really good at mugging up, you can mug up this as a formula, like specific formula, but if you go by logic, this is unitary method. So what you have to understand is the concept. Key, what is apparent volume of distribution? Key, you have given some drug and you have given some drug in certain concentration. You want to know key in how much volume this drug will be accommodated. To accommodate this drug, how much volume should be there? Like I'll just tell you, give you an idea. Let's say you have given say 1000 milligram of this drug and concentration is 50 milligram per liter, and you have given it to, you have injected it to a chuha, mouse, and you calculated that okay, you need 20 liter to accommodate this drug. Then you say, oops, the chuha doesn't even have 20 liter. So that is where the problem will come up. Okay, but in humans that is not going to be the problem. Okay, but this is the concept. The concept is this basically. Okay, so it describes the amount of drug present in the body as multiple of that contained in a unit volume of plasma. Okay, so if you have to understand the reality of the volume of distribution, so we have to talk about a lot of factors which will come up later on, like drug clearance. Okay, most important is clearance. So how much is getting eliminated? Elimination of the drug is very, very important. Other than that, these are all faltu stuff, but there is a formula, so formula can bother you, but that is what I was telling you. There is no formula, it is basic unitary method. ठीक है ना? Okay, chalo, let's proceed ahead. So we have already discussed these things. Lipid soluble drugs do not enter the cells. So if it does not enter the cell, then V, that volume of distribution, will be your extracellular fluid volume. We just gave so much example. Streptomycin, okay, gentamicin, these are all antibiotics. Okay, distribution is not only the matter of dilution, but also how much is getting attached, bound with the plasma protein and stored. So binding and sequestration is also very, very important. Okay, and then drugs extensively bound to plasma proteins are largely restricted to the vascular compartment. Again, we have again discussed these examples. So one good example is diclofenac, warfarin. Okay, volume is given as 0.15 liter per kg. Then drugs which are sequestered in other tissues may have the volume much more than the total body water. Okay, for example, there can be digoxin. I think you are understanding these things. We just did example 2 slides back. Chlorpromazine, morphine, okay, because they are present in other tissues, inside the tissues they are present. Again, you know, this is somewhere again clinical comes up, that is pathological states, certain pathological conditions like CHF, congestive heart failure. CHF, you understand? Congestive heart failure. Congestive heart failure, I hope in physiology you have a basic understanding. Your heart is failing to pump. So since your heart is, in simple language I'm telling you, since your left heart is failing to pump, so your lungs is not draining to your left atrium, so things are getting congested in your pulmonary circuit. So that's how congestive heart failure. Okay, so congestive heart failure. Uremia. What is uremia? When urea concentration increases in your blood, it's called as uremia or azotemia. Liver cirrhosis. Okay, so liver cirrhosis, when liver is not producing plasma protein, mind it. So all of these can alter the volume of distribution. Okay, so volume of distribution can be altered, permeability of the membrane can be altered. Okay, binding proteins can also change, accumulation of metabolites which can displace the drug. So these are the factors. So what do we learn about the factors? Number one is certain pathological conditions, like we discussed about the CHF, uremia, liver cirrhosis. Okay, then permeability of the membrane can also alter the V. Then binding of proteins can alter the V. Then accumulation of metabolites that can displace the drug from the binding state, that can also alter the V. So all of these can alter the apparent volume of distribution. Understood? Now talking about this graph, so this graph is pretty interesting in understanding this thing. I'll just show you here. See, if this is your concentration and this is time, and let's say that this is 100% concentration, full. So when you give IV, so when you inject directly, it reaches 100%. There is no fast pass metabolism or anything like that. So it is going to reach here. So our story begins at the top level. Normally we draw a graph from 0 and all, but here no, we have to start from 100%. If you are giving IV, if you are giving injection. So once you are giving injection, so initially in your blood there is say 100 milligram. But do you realize from the blood things will go distributed? So as things go distributed inside the blood, amount will remain same, or it will increase, or it will decrease. Decrease, yes. So as it keeps decreasing. So as it is decreasing, what is happening? Distribution is happening. Okay, and this is when only things are getting distributed and blood level is lowering. Now after a while, elimination will begin. You will go for urination, you will go for defecation, you will breathe out, you will sweat out. Now blood level will decrease rapidly, slowly, or in the same way.
Sir, very rapidly decrease also.
Of course. So now you see it is now going to decrease, like now it is going to be distribution, and gradually, so there is going to be elimination. So you see now gradually there is going to be elimination over here taking place. So if you will draw back, okay, if we will back draw it, so talking only about the elimination, so it should have been here. And if we continue with only distribution, if it had been only distribution, then let's say it would have been coming down like this. Only distribution. If it is only distribution, then blood level would have lowered, and at this point it would have reached 0. And if it would have been only elimination, then from this point elimination would have come down to 0. But that is not true. So actually it's a dynamic process. So we are getting a graph like this. So our actual graph that we get, the dynamic graph that we get, that is more of like, this is the graph that we get. So this wala portion is going to go for distribution, and this wala portion is going to go for elimination. Understood? Okay. So if you have understood this, let's move on. And here I'm going to talk about something called as a redistribution of drug. So it's very simple, not at all big deal. So highly lipid soluble drugs get initially distributed to organs with high blood flow. We have already discussed less vascular but more bulky tissues like muscles or fat. They take up the drug, and hence the plasma concentration falls. And if the plasma concentration will fall, if a drug was trapped inside your brain, then they will be withdrawn from the brain and the liver and other organs like that. Now, if I give you the example of thiopental, if you remember. Okay, if the site of action of the drug was in one of the highly perfused organ, then redistribution results in termination of the drug action. Level will get lowered. If the site of action is site of action of the drug was in one of the highly perfused organ, okay, so that will lead to the termination. Okay, now another thing that we talk about over here is greater the lipid solubility of the drug, the faster is the redistribution. Okay, so, and I hope you understand this thing. Lipid solubility and faster the redistribution. And anesthetic action of this thiopentone IV is terminated in few minutes due to this redistribution. Okay, anesthetic action that we discussed this. I think you understand that we already had the discussion about it. Now, if we talk about this hypnotic drug, so you remember I told about this hypnotic drug, sedatives and hypnotics, sleeping drugs, sleep inducing drug. So if we talk about those hypnotics, so if they are redistributed, then they have got a relatively short hypnotic action. Okay, like oral diazepam or nitrazepam. Okay, here I have written they have got a elimination half-life of more than 30 hours, but I don't want you to get bothered about it right now. What is half-life? I'll come to that in a while. Just for the time being, trust me that it is all about redistribution. Redistribution means that that dynamic equilibrium. Okay, one drug is going out, so again it is shifting here. Understanding, right? So initially there was distribution, then as elimination, etc., things happen, then there is redistribution. And when the same drug is given repeatedly or by continuous IV infusion over a long period, the low for perfusion high capacity sites get progressively filled up and the drug becomes longer acting. Okay, so there is nothing much to discuss over here, so I'm just moving on. Okay, so then these things also we have already discussed. The capillary endothelial cells in brain have tight junction and they lack large those paracellular spaces. Neural tissues, as they cover the capillaries, there is the investment of neural tissue. Which neural tissue? The glial cell, the astrocyte. So that's what it's written here, and together they form the BBB. And there is a blood CSF barrier is located in the choroid plexus, also similar thing. And both these barriers, they are lipoidal and limit the entry of non-lipid soluble drugs like again gentamicin, which I have told you a moment back. Along with the neostigmine. Neostigmine, I think last class we discussed, it is used for the treatment of this myasthenia gravis. I give you that example, physostigmine, neostigmine. Yes. Okay. Then only lipid soluble drugs therefore are able to penetrate and have action of this on the CNS. Now, okay, this is something new. There is something called as the efflux transporter, called as P-glycoprotein, that is present in brain and choroidal vessels, and they extrude many drugs that enter brain by other processes. Okay, so how do they extrude it? So I'll come to that part in a while. Okay, just as a matter of fact, you can remember dopamine does not enter the brain, but its precursor, that is the levodopa, it enters the brain. That means dopamine is a drug which I will teach you later, that there is a disease called as Parkinson's disease, Parkinsonism. So in Parkinsonism or Parkinson's disease, we can treat it by dopamine. But actually dopamine does not enter the brain. So if you can give levodopa, L-dopa, then it will actually enter the brain. So L-dopa is used in case of Parkinsonism, not this dopamine. Okay, then inflammation of meninges, there is meningitis that increases these barriers, permeability of the barrier, sorry. There is also something called as enzymatic blood-brain barrier. There is something called as monoamine oxidase. What is this thing? Even choline esterase. Okay, so not only all of these things, so these are all different enzymes which are present in the capillary wall or in the cells lining them, and they do not allow catecholamines. 5-HT is basically 5-hydroxytryptamine, which is the other name for your serotonin. Okay, so 5-hydroxytryptamine, acetylcholine, okay, they do not allow these things to enter the brain in the active form. There's a thing called as CTZ. I think last year you have studied in your neuro. Do you know what is CTZ? Full form? It's the chemical locha of your brain, the chemical trigger zone, vomiting center, etc., they're present over here. Remember, So why does these chemicals, they affect it so much? Because of this reason, that if you talk about this CTZ, here the blood-brain barrier is deficit. Okay, there is a deficiency of the blood-brain barrier. Now since there is deficient blood-brain barrier over here in the medulla oblongata, so the lipid soluble drugs are lipid insoluble drugs which are there, they are like emetic. Emetic means cause vomiting, because that's CTZ, that is the vomiting center. Okay, and not only at medulla oblongata but also at some periventricular sites. And exit of drugs from CSF and brain is not dependent on lipid solubility and is rather unrestricted. Understood? Okay, moving on. And okay, a large volume of distribution has an important influence on the half-life of the drug. Now, what is half-life? I will discuss it later on. For the time being, trust me that it is a point of elimination. It is a way drugs get eliminated, removed from your body. Delivery of drug to the organs of elimination depends not only on blood flow but also on fraction of the drug in the plasma. If the volume of distribution of the drug is large, most of the drug is in extraplasmic space and is unavailable for excretory organ. I think we have discussed all of these things, So I've explained all these things, the distribution, ECF, ICF, interstitial space, plasma, blah blah blah. So okay, so those things are written over here. So I think you have got a idea about that entire distribution part. So what I'm trying to say is, in the first slide I told you about the, like, first is oral administration, oral route administration, then absorption, then distribution. So I'm done with distribution right now. After distribution, the next thing that was there, that is metabolism. So I think now it is time that we are going to talk about metabolism. Now metabolism is called as biotransformation. You have to transform the drug through certain biological ways. So that is what is called as a biotransformation. So if you can observe it here, biotransformation, what does it mean? It means the chemical alteration of the drug in the body. Why do we need it? Because certain drugs, they are non-polar, okay, lipid soluble. So can you eliminate these drugs easily? No, right? So you have to make it polar. A simple funda, your bile. In physiology, you must have read about something called as unconjugated bilirubin and conjugated bilirubin. So why unconjugated bilirubin, and what is the difference between unconjugated and conjugated bilirubin? So if it is unconjugated bilirubin, that means that is a bilirubin that is non-polar. If it is non-polar, that bilirubin is not excreted out from your body. So bilirubin is produced from blood basically, so in your spleen. Then when somebody develops jaundice, why do we blame the liver? Because it is liver's job to convert that unconjugated bilirubin into polar bilirubin, conjugated bilirubin. And if it is polar, only then it can actually get eliminated through your kidney. So that is biotransformation. So I give you a good example of biotransformation about unconjugated bilirubin and the conjugated bilirubin on a physiological scale. Same thing should happen over here. So this is required to render a non-polar, that is a lipid soluble compound, into polar or a lipid insoluble portion. So they are not reabsorbed in the renal tubules and are eliminated. So most hydrophilic drugs like gentamicin, neostigmine, decapithonium is also there. They are not biotransformed and are excreted unchanged. Okay, same reason. So primary site is liver, but other sites are also there: kidney, intestine, lungs, and plasma. Okay, so when we talk about this biotransformation, so you should remember that there can be three things possible. Either there can be inactivation, or there can be active metabolite from an active drug, or there can be activation of inactive drug. So we can do it in three ways. Like if it is inactivation, so it's written, you can see that most drugs and their active metabolites are rendered inactive or less active. For example, lidocaine. Lidocaine is a local anesthetic. You are going to be dental surgeons, so you need a lot of lidocaine. Ibuprofen, I hope everybody knows this, it's painkiller. Paracetamol, everybody knows it. Chloramphenicol is a antibiotic. Propranolol, again, I just discussed it. It is a central nervous system acting drug. Okay, and its active metabolite 4-hydroxypropranolol. So what happens is they need to become inactive. So after metabolism, they become inactive. Active metabolite from an active drug. So many drugs have been found to be partially converted to one or more active metabolites. The effects observed are the sum total of that due to the parent drug and its active metabolites. Okay, we will see to it later on. And another thing is the activation of the inactive drug. So few drugs, they should be converted. Okay, now they need conversion in the body to one or more active metabolites. So now here comes up a concept of prodrug. So prodrug is basically the inactive drug. So prodrug has to get converted into a drug. So prodrug is inactive, drug is active. So this can also take place. So inactive drug can also be converted into active form. Understood, everyone? All right. Okay, yes. So okay, so understood, everyone. So prodrug actually may offer some good part also, advantages over the active form in being more stable, having better bioavailability or other desirable properties. So this we will discuss, do not worry about it. So let's proceed ahead. Okay, now if we talk about this classification, there are two ways it can happen. So when you take a drug, like I discussed just now, that there is something called as conjugation, like bilirubin, unconjugated bilirubin and conjugated bilirubin. So same way, a drug can also undergo conjugation, and also a drug can undergo oxidation. So two ways it can be done. So a drug can undergo oxidation and also it can undergo conjugation. Okay, so if it is activation, so we are going to, like, if sorry, oxidation, then we will call it as phase 1, and if it is conjugation, then we are going to call it as phase 2. So phase 1 is non-synthetic because you don't synthesize anything here, and phase 2, conjugation you create a new product, so that is why it is synthetic, or phase 2. Phase 1 is a functional, like a functional group may be generated or exposed, and the metabolite may be active or inactive. And the phase 2, this is where a metabolite is mostly inactive here, because like I said, like conjugated bilirubin wala funda. Okay, so this is the basic flowchart, and now we have to we will discuss what happens over here. So this part is again going to become a little bit tricky, so I don't think today we should continue with this. So I think next class let's continue this part about this biotransformation, because this is a portion where I want you to be a little bit more active, because here there will be a little bit of, like, not lot really, but there will be certain chemistry present over here. Okay, anyways, so let us stop.